There are two patient populations that I would choose tocilizumab as a first-line biologic treatment. First, a patient who can't tolerate methotrexate, and I intend to use biologic as a monotherapy because of the result of that DACTA study. The second group of patients are patients with very predominant systemic manifestations, patients who have very high CRP, who may be anemic or have hypoalbuminemia, because all these are biologic effect of interleukin-6. So one would predict that this patient will respond particularly well to IL-6 blockade. So I think there are at least two reasons why TNF inhibitors works better in combination with methotrexate. First, the biologic effect of TNF inhibitors mainly works on the monocytes and the innate immune response. There's little evidence to suggest that TNF inhibitors suppress T and B cell function, while methotrexate does work on T and B cells. And it is because of this effect that methotrexate probably inhibits the formation of neutralizing antibodies. So methotrexate is synergistic with TNF inhibitors. With interleukin-6, IL-6 has effect both on the adaptive and the innate immune response. So it covers both arms of the immune reaction. So this may be one reason why tocilizumab doesn't seem to have as much synergism with methotrexate compared with the TNF inhibitors. In any patients, there are several considerations to be made in choosing a biologic treatment. First, one has to estimate the likelihood of benefit, the likelihood of risk. In that, these are based on the profile of the biologic therapy. And the second is to think about costs, the likelihood of the patient's and patient's choice. So, for example, for certain treatment, patient may prefer to have intravenous infusion versus subcutaneous injection, and vice versa. Well, first of all, we know that from recent research that patient compliance to oral treatment is not very high. So recent studies suggested that for patients who are taking 80% of the medications as prescribed, only 20% of patients do that. That may be due to a number of reasons, minor side effects, forgetfulness, whatever, but these kind of incompliance does affect the efficacy of any given treatment, and it's something that we need to address in everyday clinical practice. Mm-hmm. So methotrexate intolerance has been increasingly recognized through better tools to monitor patients' compliance to treatment with electronic tagging of tablets. Many patients actually don't complain to physicians about minor side effect to methotrexate because one, they know that the treatment is working to some extent, and they don't want to upset the clinician because clinician prescribing treatment, they are grateful for the treatment they receive, so they think that if they complain about minor side effect, the clinician may be slightly upset as a result. What increasingly recognizes the patient often complain to our nurse specialists when they come for monitoring clinic about minor side effect. And these minor side effects do affect the patient's quality of life. And as a result, with tighter monitoring of methotrexate compliance, we increasingly recognize that as a problem. And in fact, we recognize that more than 50% of our patients are not taking methotrexate as it should be prescribed, and often it may be due to side effects such as nausea, loss of appetite, dizziness, or hair loss. Many of these are not very severe, but sufficient for the patient not to want to take the methotrexate as regularly as prescribed.